It was a pleasure to see you all this morning. My name is Jordan Perchik. I am a fellow in abdominal imaging and informatics at the University of Alabama, Birmingham. And it is my pleasure today to introduce Dr. Jubal Watts to give this presentation on idiopathic interstitial pneumonias. He is an attending with the Veterans Affairs Hospital in Birmingham and the University Hospital also in Birmingham, with national and international recognition in chest imaging, and certainly personally, from the resident perspective, gives some of the most impactful lectures and board reviews. So it's our pleasure to share him with you today. And without further delay, I'll pass it over to Dr. Watts.
Great. Thank you, Dr. Perchik. So my topic is going to be the high-resolution CT of idiopathic interstitial pneumonias. So dealing mainly with interstitial lung disease, which is sometimes not the most popular topic, but it is important because it's becoming increasingly recognized, and there's prognostic significance and some treatment options. So it's good to be able to recognize what the different types are and how to kind of triage the best appropriate management. And I do have a disclosure. I'm on the Speakers Bureau for Boehringer Ingelheim, but that won't be relevant for this topic. So the idiopathic interstitial pneumonias, this is the most recent update on the idiopathic interstitial pneumonias, and it was in 2013 in the American Journal of Respiratory and Critical Care Medicine. Before this, they only had 7, and they kind of changed them around a little bit, but the idiopathic interstitial pneumonias are now divided into major and rare, and the major ones, and we'll spend a fair amount of time on it. The most common one is idiopathic pulmonary fibrosis. Idiopathic nonspecific interstitial pneumonia is an idiopathic interstitial pneumonia, but it's very uncommon for it to be truly idiopathic. It's usually seen in relation to connective tissue diseases or people with drug reactions. You can have a NSIP type pattern of lung injury from a drug reaction. Respiratory bronchiolitis and desquamative interstitial pneumonia are considered idiopathic pneumonias, but they're generally smoking related. And then cryptogenic organizing pneumonia is just organizing pneumonia with no known cause. We won't talk about acute interstitial pneumonia. This is used to be called Hammond-Rich or AIP, and all it is idiopathic ARDS. So the imaging manifestations are ARDS, but you just don't have a known cause. And then the rare idiopathic interstitial pneumonias include LIP or lymphoid interstitial pneumonia, and then idiopathic pleuroparenchymal fibroelastosis. And then they did add a new category for unclassifiable idiopathic interstitial pneumonia. So I typically do these as kind of case presentations, and we'll show the images first and then talk about them to give people kind of time to look and make up their kind of assess and see what they think is going on. So this is case number 1. Oh, we got something in the chat. Sorry, I was looking at the chat. So we'll scroll down. You can see even here in the upper lobes, they're not normal. You have what looks like some holes in the lung, some black spots that are a little darker than the gray next to it, some reticulation. You see kind of these coarse lines in the lungs abutting the pleural surface. But the further we come down, we can see the disease gets much worse. So here we are in the bases, and there's a lot of abnormal lung. So we'll kind of focus on this image. One thing to realize is that there's normal lung here. Like it's not diffusely abnormal. There is some areas of normal lung, but around the periphery, so basilar and subpleural are kind of the buzzwords for the distribution of this disease. Around the basilar and subpleural lung, you see these holes, and these holes are what we call honeycombing. They're little cysts, usually between 3 millimeters and 1 centimeter, and they have to abut the pleural surface. They can't stack up on top of each other, but they at least have to start at the pleural surface. If you see holes in the lung like this that don't start at the pleural surface, you just see them kind of in the middle of the lung, then that is not honeycombing. That would be what we call non-honeycomb cyst-like changes and would be differential. So we have basilar and peripheral reticulation with traction bronchiectasis. You can see some of these bronchi are going into the subpleural lung are dilated, and we have honeycomb type cysts. There's no real ground glass density. And we see areas of normal lung. The pattern is spatially and temporally heterogeneous, meaning we have areas of normal lung, we have honeycomb lung, which is end-stage fibrosis, and then you have reticulation and traction bronchiectasis. So this is a typical UIP pattern. And a UIP pattern of lung injury is the most common pattern you'll see in idiopathic pulmonary fibrosis, which is one of the most common interstitial idiopathic, well, it is the most common idiopathic interstitial lung disease. And it is characterized by basilar and peripheral predominant reticulation with traction bronchiectasis and honeycomb-like changes. It has to have, you have to not have inconsistent features, which inconsistent features would be a substantial amount of ground glass. If you have nodules, that can make you think of other diseases like sarcoid, and you cannot have significant air trapping. If you see significant air trapping, then it more likely is going to be hypersensitivity pneumonitis, which can kind of have a UIP pattern of lung injury, but will show on, if you have expiratory images, will show nice degrees of air trapping. One thing about ground glass, we define ground glass, or Fleischner does, as an abnormal attenuation of the lung so much that it doesn't obscure the underlying lung architecture, the vessels and airways. Anytime you have a substantial amount of reticulation, like up here, it'll look ground glassy, but when we're trying to classify high resolution chest CTs in terms of whether or not it is a UIP pattern, we kind of ignore the ground glass if it's only in the areas of reticulation. Histopathologically, that corresponds to microscopic fibrosis, microscopic honeycombing. And so for you to have ground glass that would make it inconsistent with UIP or suggest an alternative diagnosis, you need to see it clearly away from areas of honeycombing. ATS in their original guidelines said it has to exceed the areas of reticulation. Fleischner Society says you need to see ground glass clearly away from areas of reticulation to make it, to call it inconsistent. So this is a typical UIP pattern, spatially and temporally heterogeneous. It has with this HRCT pattern, you can make a clinical diagnosis of idiopathic pulmonary fibrosis in the right clinical setting. So UIP is a pattern of lung injury. It is not in and of itself a disease, but the most common cause for a UIP pattern of lung injury is idiopathic pulmonary fibrosis. So by definition, it's idiopathic, meaning they can't have another cause for their fibrotic interstitial lung disease. So if they have rheumatoid arthritis or they have scleroderma, they cannot have IPF. It's not possible. They have either rheumatoid lung or connective tissue disease related interstitial lung disease. They cannot have a known connective tissue disease. They have to have negative serologies. They have to have not had significant exposures. So if you see kind of the same pattern, but they have a lot of asbestos related pleural plaques and they have asbestosis, not idiopathic pulmonary fibrosis. But with a typical HRCT, if you've ruled out exposures, the serologies are all negative, there's no connective tissue disease, you can make a clinical diagnosis of IPF and don't need to do a lung biopsy. And that's important because the lung biopsies for interstitial lung disease are usually VATS, as you've got surgical lung biopsies, and they're associated with some morbidity. They can cause acute exacerbations, and people can sometimes, there's a not insignificant morbidity and mortality rate from doing a surgical lung biopsy on people with interstitial lung disease. So you want to avoid the lung biopsies if you can. Sometimes you can't, but if they have a typical UIP pattern, then you can. There would be no reason to biopsy a typical UIP pattern. There's also a pattern called probable UIP. We used to call it possible UIP until the ATS updated their guidelines. And probable UIP is exactly the same, except that you do not see clear honeycombing. So you have basilar and peripheral predominant reticulation with traction bronchiectasis, an absence of inconsistent features like ground glass nodules, air trapping, or like ground glass opacities, air trapping, air or nodules, and you just don't see the honeycombing. So a probable UIP pattern, we see a fair amount. And now the recommendations generally are not to biopsy that either. If you have a typical UIP pattern and you do go to surgical lung biopsy, the odds of it coming back as pathologic UIP is very high, 92 to 95%. If you have a probable UIP pattern and you go to surgical lung biopsy, the odds of it coming back histopathologically as UIP is about the same. It's like 88 to 90%. So there's not much difference. And so we're trying to avoid the risk, the morbidity from the surgical lung biopsies. So now most places will not biopsy a probable UIP pattern. So on the coronals, you can also see the distribution. One thing about a true UIP pattern is it kind of climbs the sidewalls. It is basilar and peripheral predominant, but it will climb up the sides of the lung. And you can see how this is kind of climbing up. You'll almost always have some upper lobe involvement, but it'll be less than the involvement in the lower lobes. And it'll be spatially and temporally heterogeneous. So histopathologically, UIP is also spatially and temporally heterogeneous. For the pathologist to make a pathologic diagnosis of UIP, they need to see areas of normal lung. So if they don't see any normal lung, then they can't really call it UIP. They also need to see end-stage lung, which is microscopic fibrosis, microscopic honeycombing. And then they need to see fibroblast foci, so areas, cells that are actually laying down collagen in the lung. And so if they see all those things in an absence of inconsistent features, then histopathologically, it's UIP. So UIP is spatially and temporally, it's very heterogeneous on the CT scan. You have normal lung next to end-stage lung, and it's also spatially and temporally heterogeneous on path. And that'll be different than the non-specific interstitial pneumonia or NSIP, which we'll talk about in a little bit. These are just the expiratory images showing you that there's no real air trapping. So if there was air trapping, you'd see multiple kind of loosened areas that would persist on the that would look exaggerated on the expiratory imaging, which we don't see. One thing is if you don't do a lot of HRCT imaging, we like to do both inspiration and expiration. The biggest role of that is to actually look for air trapping, because hypersensitivity pneumonitis can be a mimic for UIP and IPF. Expiratory images should have the posterior tracheal, the membranous portion of the trachea, the posterior tracheal wall here should be flat. So when you breathe out, the membranous portion, the area without cartilage should be flat. If you have inspiratory scan, and I'll go back real quick to the axials. On a good inspiratory scan, the trachea should be round. Got a little hiatal hernia. So here we're back to the trachea, and you see how round it is? So round. So on expiratory scans, it should be flat. If the tracheal morphology looks the same on both the inspiration and expiration scan, then you don't have two different scans. You have either two inspiratory scans if it's round on both, or two expiratory scans if the posterior membranous portion of the trachea is flat on both of them. So that's just one internal quality control you can do to make sure you're getting adequate expiratory imaging, because sometimes it's hard for to coach the different patients, and sometimes they're real short of breath and have a hard time regardless. But this was a good expiratory scan. There's no air trapping, no nodules, no ground glass. So this would be typical UIP for the reasons we described, and we'll go over some more of that. So IPF used to be called cryptogenic fibrosing alveolitis. That's kind of not a term used anymore, but you'll see subpleural basilar reticulation, honeycombing, traction bronchiectasis, and ground glass. You can have volume loss. You will have some volume loss. If they have emphysema, because there's a higher risk of IPF in smokers, the lung volumes can actually kind of look normal because you've got some of both. If you don't have the typical pattern or a probable pattern, you need biopsy. And most patients tend to be former smokers. The pathology, a UIP pattern, like we talked about, is spatially and temporally heterogeneous. They will have characteristic fibroblast foci, and then various degrees of interstitial inflammation. So if you have a good HRCT or a confident HRCT, you don't need to do the biopsy. One thing about IPF is that they have a high risk of cancer growing in the fibrotic lungs. Having pulmonary fibrosis puts you at a high risk for cancer. Frequently squamous cells, but I've seen a whole lot of adenocarcinomas in the areas of honeycombing too. So I don't know. It is typically either squamous or adeno. Tends to occur in older populations like 55 and above, 65 and above, more common in males, and has without treatment, it has a very poor prognosis. Median survival varies depending upon the study, but it's around 3 to 4 years, which is worse than a lot of malignancies. There is a differential asbestosis. You'll see kind of the calcified pleural plaques. Fibrotic HP, we used to call chronic HP. You'll see sparing of the posterior basis typically, and you'll have air trapping. If they have rheumatoid arthritis, they'll have manifestations of that you wouldn't see with IPF. Same with scleroderma, and they'll have the dilated esophagus with scleroderma. And then drug reactions can appear similar. Some drugs, macrodantin, can actually give you kind of a UIP pattern of lung injury, but the fibrosis won't progress once they're off therapy. So there are ATS guidelines on how to make the diagnosis of idiopathic pulmonary fibrosis, and these are the most updated guidelines from 2018. And they talk about how to do your HRCT scanning, and we won't spend a whole lot of time on it, but you want volumetric imaging. You don't want to do the old-fashioned way we used to do HRCTs, is we would get a millimeter slice at a 10 millimeter gap or 1 centimeter gap. And so you'd have 30 or 40 kind of images through the lung, but you would be only sampling about 10% of the lung. Now they do recommend volumetric imaging at 1 to 1.5 millimeters or less throughout the entire lung. You can do the old-fashioned technique for the prone and expiratory images, but you need at least one full volumetric scan. And the main reason for that is because we see a lot of nodules that we need to follow up. And if you're doing the old-fashioned technique, you don't know, because of where the slice may be, if you're catching the nodule at the widest part of it, or you may just be catching the top of it. And so when you repeat the scan, there's no real good way to tell if it's actually grown. It may look smaller, even though it's the same, or a little bigger. It may look bigger, even though it hasn't changed. So we do recommend you get at least one full volumetric image in inspiration. And so these are the terms we use when we're describing the patterns of lung injury on HRCTs when we suspect somebody has an interstitial lung disease. And so UIP, or a lot of people, because Fleischner says typical UIP, subpleural and basilar predominant, heterogeneous, honeycombing. They'll always have some traction bronchiectasis. Probable UIP is the same, but without the honeycombing, and they can have some mild ground glass densities, but it needs to be less than that of the areas of reticulation, or needs to be limited to the areas of reticulation. And then there's indeterminate for UIP. So this is when it can be subpleural and basilar predominant, but it has other features that would suggest it may not be IPF. So maybe they have some air trapping, but it's mild, but they have no exposures, but the degree of air trapping would make it HP without a possible exposure history, a reasonable differential. Or if they have some like upper lobe ground glass densities, kind of non-specific looking, but everything else looks like UIP, then you would call it indeterminate for UIP. And those patients may need biopsy. And also, according to ATS, if the disease is very mild, if they have just very subtle reticulation, but without traction bronchiectasis, so very early looking UIP, they would say call it indeterminate. And then they have the findings that would actually suggest an alternative diagnosis, not UIP. And this is when you see cysts. If you see true cysts in the lung, you would think about your cystic interstitial lung diseases like DIP, LIP, bird hog Dubé and those other things. If they have marked mosaic attenuation, that would imply generally air trapping. So you'd think about HP. If they have a lot of ground glass densities, that can be some other process. Micronodules you can see in sarcoid. Central lobular nodules you can see in HP or smoking related interstitial lung disease. And then if the distribution is bad, if it's perilymphatic or peribronchovascular, that would make you think of sarcoid or HP, and if it's upper or mid lung predominant. And then if you see pleural plaques or a dilated esophagus or clavicular erosions, you would suspect some other process. Also, pleural effusions and pleural thickening is uncommon in IPF. And so, well, they can have some pleural thickening, but if you see pleural effusions or other manifestations of serositis, you would think about connective tissue disease. So before the ATS came out, the Fleischner Society came out with a white paper, and it is about the same. So people kind of use the same terminology. One of the differences is that Fleischner says typical UIP, and a lot of people use that term because it makes it easier to distinguish than probable UIP. So typical UIP or UIP means you have honeycombing. Probable UIP, everything is the same as typical UIP, but no honeycombing. And then they have indeterminate, and then they say most consistent with a non-IPF diagnosis, so same as kind of alternative diagnosis. And they talk about how to do your imaging. You want thin sections, volumetric CT, you want some prone and expiratory imaging to look for. Well, the expiratory imaging is to look for mostly hypersensitivity pneumonitis. You do the prone imaging because the earliest manifestations of UIP and some other interstitial lung diseases, specifically asbestosis, the earliest manifestations are in the posterior bases. So if you're supine, you can get a little bit of dependent atelectasis or ground glass, and it can be hard to tell if it's really reticulation, early reticulation, or if it's just atelectasis. So if there's any question, I do recommend some prone imaging just to look for very early or mild disease limited to the posterior bases. And they talk about the mortality, the risk from doing surgical lung biopsies, which are not trivial. You can see 90-day mortality of 3.9% in the UK. So we're trying to avoid biopsy. So we biopsy indeterminate or alternative diagnosis unless we're pretty confident in the alternative diagnosis, but we don't biopsy typical UIP or probable UIP because almost always it comes back as UIP on path, and so it doesn't add much. They did update the ATS guidelines in February of 2022. These are new they didn't update the diagnostic criteria, but they did say you can do cryobiopsy in high volume centers that have experience with cryobiopsy as an alternative to surgical lung biopsy. Otherwise, you kind of need a surgical lung biopsy. Cryobiopsy it can be a good technique, and it does cause some bleeding. So a lot of places are not comfortable doing it because the risk of bleeding is much higher than just your typical transbronchial biopsy. And then they came up with another terminology they use, which is just progressive pulmonary fibrosis. And this means you have worsening pulmonary fibrosis. So you show some progression on imaging or physiologic progression, PFTs, or worsening symptoms. So PPF is progressive pulmonary fibrosis. That's different than PPFE, which is pleuroparenchymal fibroelastosis. But if somebody is progressing, if their fibrosis is progressing, then that can be an indication for certain therapies. All right, so we'll go to a different case. So we're still talking about UIP, and so the most common pattern, or the most common disease with a UIP pattern of lung injury is certainly IPF, but IPF is not the only disease that can give you a UIP pattern of lung injury. So if you look at this image, when we come to the bases, so the upper lobes didn't look that bad, like probably didn't look as bad as that other case of the initial case, which was IPF. But when we come down to the lower lobes, we see kind of what looks like severe honeycombing. And so this is a little different because we don't have the normal lung next to the kind of peripheral honeycomb lung. At least in the bases, everything is honeycombing. We come up a little higher, there are some areas of normal lung. some ground glass, but it's really kind of limited to the areas of reticulation and traction bronchiectasis. So this would meet the criteria for UIP. There's no nodules, there's not significant ground glass, there is honeycombing, traction bronchiectasis. But if we look on the coronals, it looks different than the last case. And this is because this is somebody with connective tissue disease. This is somebody with scleroderma who has a UIP pattern of lung injury. And it was described in a fairly recent paper by Dr. Jonathan Chung that there are some manifestations of CTD ILD with a UIP pattern that are different than IPF. And one of those is what they call the straight edge sign. So if you remember on the case before, we talked about UIP and IPF climbing the sidewalls. You saw it come out and then it would come up. It doesn't respect fissures or segments. In CTD, you can get this kind of straight edge sign. It was termed the straight edge sign. And they also described the exuberant honeycombing sign. So you have kind of exuberant honeycombing, more severe than the other case we saw, but kind of limited to the lower lobes with a straight edge sign. And so if you see that straight edge sign or exuberant honeycombing, you want to think closely about connective tissue diseases and run your serology panels and maybe get the extended myositis panel, because sometimes that'll show up when the other serologies are negative. But this was the paper. It was an AJR in 2017, and they described the straight edge sign, which we saw, the exuberant honeycombing sign. They also described an anterior upper lobe sign, which I don't have. That wasn't a good example, but for some reason, people with a UIP pattern in connective tissue disease will get disease in the posterior bases, and the anterior upper lobes will look worse. And so that was some things they noticed about UIP patterns in people with connective tissue disease is not idiopathic pulmonary fibrosis. So we'll move on to case 2, and this will be a different pattern of lung injury, and I'll scroll through and y'all can decide what you think. So this looks different. When we get to the bases, this is very homogeneous looking. You have kind of diffuse ground glass, a lot of traction bronchiectasis, no honeycombing. And in fact, if we look at the immediate subpleural lung, it's kind of spared. So there's subpleural sparing, diffuse ground glass, reticulation with traction bronchiectasis, and no honeycombing. And this is typical NSIP pattern, so non-specific idiopathic pneumonia. Now, it can be its own disease, but almost always it's associated with a connective tissue disease or manifestation of a drug reaction. So NSIP gives you ground glass densities, reticulation. It can, there's different types. So there's cellular, fibrotic, and mixed NSIP. The cellular NSIP is the best type to have because you just have an inflammatory cellular infiltrate that will respond to immunosuppression. Fibrotic NSIP is worse because once you lay down collagen, it doesn't go away. Regardless of if it's cellular or fibrotic, NSIP does have a much better prognosis than IPF. It's usually the 50% survival rate is out to 10 years or more, as opposed to 3 to 4 years with IPF. So much better prognosis, even if it's fibrotic. And this would be a case of fibrotic NSIP because you see the reticulation, ground glass, and traction bronchiectasis. So in NSIP, the traction bronchiectasis is a little different than what we see in UIP, IPF, because that starts at the periphery and kind of moves in. So the traction bronchiectasis will always be worse at the periphery. In NSIP, it tends to be more kind of diffuse and homogeneous. You'll see it coming all the way back up to the hilum almost, the same degree of traction bronchiectasis, or at least in the areas of lung that are involved. And if you look, it's hard to tell because these are lung windows, but this is the esophagus, and it's very large, and you can see air fluid level in it. And this was a patient with scleroderma. So NSIP is the most common pattern of lung injury in patients with scleroderma. About 70% of scleroderma patients will have an NSIP pattern. Around 25–30% will have a UIP pattern. And the reverse is kind of true for rheumatoid lung. Most people with rheumatoid lung will have a UIP pattern, but about a quarter or 30% will have an NSIP pattern. So you can see an NSIP pattern in many different types of connective tissue diseases. But scleroderma is kind of the classic, and this was a case of scleroderma. So NSIP is spatially and temporally homogeneous. Everything looks the same. You don't see normal lung next to end-stage lung. And that's also true on histopathology. They'll have the same degree of fibrosis, the same degree of cellular inflammatory infiltrate on path. There won't be normal lung. And so the spatial and temporal homogeneity is kind of the buzzword for NSIP as opposed to UIP, which is spatially and temporally heterogeneous. And here you can see it's kind of basilar predominant. It can give you kind of a similar straight edge sign, but there's no exuberant honeycombing. But it is the kind of same distribution as the connective tissue disease patterns in UIP. So NSIP, relatively new, first described in '94. It is a specific interstitial pneumonia, even though it's called non-specific interstitial pneumonia. Sometimes I wonder, we sometimes use the term unspecific interstitial pneumonia when we really don't know what we're looking at. But NSIP is a well-described pattern of lung injury. You'll see ground glass opacities, fibrosis, minimal, if any, honeycombing, lower lung predominant, subpleural sparing. So the subpleural sparing can be helpful. You only see it in about 50% of the cases, but when you do see it, it's helpful. And there's three types, varying depending on how much fibrosis it is. And obviously the better prognosis is with the least amount of fibrosis. And it presents similar to other interstitial lung diseases, chronic progressive dyspnea. NSIP, because it's usually connective tissue disease related, tends to occur in a younger population, so 40 to 50-year-olds, more common in females because connective tissue diseases are more common, and no association with smoking. And they do better than people with UIP. A lot of people will recover completely with immunosuppression. NSIP typically requires a VATS or an open lung biopsy. You can't make a clinical diagnosis of idiopathic NSIP like you can idiopathic pulmonary fibrosis. If they have an NSIP pattern of lung injury and all the serologies, everything's negative, they've had no exposures, it still requires a biopsy. We don't biopsy it a whole lot because we tend to kind of follow them, checking serologies. And even if the serologies are initially negative, after a year or so, a lot of times they'll convert to a actual recognizable connective tissue disease. All right, we'll go on in the interest of time. One other type of connective tissue disease that can give you a fairly recognizable pattern is polymyositis, dermatomyositis, or antisynthetase syndrome. And a lot of times it will give you severe lung disease that'll be kind of a combination of an NSIP and organizing pneumonia pattern. So it looks very busy. You've got a lot of ground glass, some consolidation. We do see kind of areas of subpleural sparing. You can see the subpleural lung here is spared. We come down, there's a lot of subpleural sparing here. So part of it looks like NSIP, especially with the subpleural sparing and the ground glass, but it's much more heterogeneous than the prototypical case of NSIP. And you see other areas, like we have what looks like a pretty good reverse halo here, which you'll see in organizing pneumonia. And so if you see what looks like a combination of NSIP and organizing pneumonia, think about antisynthetase syndromes or polymyositis, dermatomyositis, because they can frequently present with a combination of the two. And here's what it looks like on the coronals. All right, so on to a different case. So this was a 8-month history of progressive dyspnea, minimal sputum production, and I'll scroll through and people can. I'll tell you, this was a suture material from a vat. So they had a surgical lung biopsy. So this was path proven. So the predominant abnormality in this case is ground glass density. We see a lot of ground glass opacities. Here you can see ground glass. It's more dense than the lung kind of next to it. We come up, there may be some kind of ill-defined centrilobular nodules out at the periphery here, a few punctate tiny nodules, but pretty extensive ground glass. And there are also some fairly discrete non-honeycomb-like cyst or non-honeycomb cyst-like changes. If you look, here's subpleural lung, and there's lung there. And so these are holes in the lung, but they're not abutting the pleural surface. So this is not honeycombing. This would be non-honeycomb cyst-like changes. So you have diffuse ground glass densities, some scattered non-honeycomb cyst-like changes, and then some upper lobe poorly defined centrilobular nodules, and probably some upper lobe emphysema. Sometimes it can be, when there's diffuse ground glass, it can make emphysema look like it has perceptible walls when it really shouldn't, because it makes it more conspicuous. But this is DIP, so desquamative interstitial pneumonia. So this almost always is associated with smoking. People typically have heavy smoking histories. The predominant abnormality will be ground glass. They also have a little nodule there that's probably not related. The predominant abnormality will be ground glass, but you can also see non-honeycomb cyst-like changes, especially in the areas of ground glass. They'll frequently have emphysema, and they will have manifestations of respiratory bronchiolitis, those poorly defined centrilobular nodules. DIP is in a spectrum of smoking-related lung injuries. So all smokers, even if they're asymptomatic, will have respiratory bronchiolitis, which is like the smoker's macrophages that surround the terminal airways. If they become symptomatic from that, then it's respiratory bronchiolitis, interstitial lung disease, ILD. And on imaging, what that will manifest, if it's RB-ILD, will just manifest as the poorly defined upper lobe centrilobular nodules, smoking-related respiratory bronchiolitis. They'll be centered around, they're centrilobular, centered around the distal airways. When those smokers' macrophages kind of spill out into the alveoli, they start filling the alveoli, you start seeing more kind of diffuse ground glass, and that's when it becomes a DIP. The desquamative interstitial pneumonia is kind of a misnomer because nothing actually desquamates. The smoker's macrophages just proliferate and spill into the alveoli, but we still call it DIP. It generally has a pretty good prognosis with smoking cessation. Sometimes they'll give steroids. I think the data on steroids is not great, but generally responds well to smoking cessation and doesn't progress. Rarely it can progress to kind of an end-stage lung disease that may need transplant, but generally responds to smoking cessation. We're getting better at kind of recognizing these smoking-related lung diseases, so we're biopsying them less and less. But this was an older case where we did have path proof, and this was kind of a typical DIP case. And here's the expiratory images. You can see the membranous trachea is flat. We've got some air trapping, not severe though, like you would see in cases of HP. Here is just a different case of DIP. And this I like because if you don't look closely, you can miss the kind of diffuse ground glass. So up in the apices, this is kind of the normal lung. We just see a little bit of normal lung at the periphery. Everything else is diffuse increased ground glass. So you'd say, I mean, just looking at it, this patient had a DLCO of like 40. You'd wonder why their DLCO was so low. It's because all of the lungs are abnormal. They have, they're partially filled with macrophages. And the only normal lung you see is here. So I like this case because it's kind of diffuse ground glass. And we do see a fair amount of centrilobular emphysema. You see what these look like cysts, and you could probably call them cysts. It is DIP, but I think we kind of see the wall because of the diffuse ground glass more conspicuous than we should. Some of these nodules have a central dot in the middle. And usually when you see kind of a centrilobular dot in the middle of a hole in the lung, that's going to be centrilobular emphysema. There are a few other things that can give you that central dot, but usually it's centrilobular emphysema. And this is also a path-proven case. So DIP, misnomer, it's a continuum of smoking-related lung injury. RBILD will progress to DIP over time. The radiographic findings are kind of non-specific. You can see vague opacities, the ground glass densities. You can have some basilar linear opacities and mixed with consolidated lung, but the diagnosis is generally made on the HRCT, and the predominant abnormality is ground glass density. It can be diffuse. A lot of times when it progresses, it becomes more lower lung predominant. Most cases I've seen have been kind of diffuse. You can see some reticulation, but true fibrosis and honeycombing is not common in DIP. You do see the small cysts in areas of ground glass. They tend to be thin-walled, and because it's a smoking-related disease, you'll see emphysema in a lot. And so the differential RBILD is kind of the same disease, just limited to the distal airways. So you don't see the diffuse ground glass densities, you just see the centrilobular nodules. And so most occur in smokers. They can have restricted PFTs, decreased DLCO, tends to occur in a younger population than gets UIP, IPF, and more common in males. So prognosis is, well, with DIP, it's worse than RBILD, but it's pretty good overall. Rarely it'll progress with smoking cessation and steroids. Is there the microscopic features? I'll leave those in there because we talked about that. It's the smoker's macrophages. Here's just an example of a mild case of RBILD where they've highlighted these kind of poorly defined upper lobe centrilobular nodules. And there's another case of kind of more severe DIP where you have the ground glass and the non-honeycomb cyst-like changes versus emphysema in the areas of ground glass. One thing that's important to differentiate, because it can also give you these centrilobular nodules, is hypersensitivity pneumonitis. So HP gives you poorly defined centrilobular nodules, can look similar to RBILD with the ground glass densities you can see in DIP also, but they tend not to have as much emphysema, and they tend to have a lot more conspicuous air trapping. And so this is just an example of some poorly defined centrilobular nodules in somebody with non-fibrotic hypersensitivity pneumonitis. And here's an example of fibrotic hypersensitivity pneumonitis, which can kind of be a mimic for UIP with the honeycomb changes in some cases, but it tends to spare the posterior bases and be upper lobe predominant. And here you can see that kind of air trapping, mosaic attenuation in the bases. So HP is a mimic. It is not an idiopathic interstitial pneumonia, though. Here's some more examples of HP and how it can be a mimic for UIP especially, or fibrotic HP can be a mimic for UIP, but you'll see the nice conspicuous mosaic attenuation and air trapping, which you don't expect to see in UIP, IPF. All right, how are we doing? Here's another case, progressive dyspnea and fever, no improvement with community-acquired pneumonia, antibiotic therapy. I don't know the age of this patient, probably 40s, I would guess. So I'll scroll through and y'all can take a look. Oh, there's a chest x-ray. So did not get better on antibiotics, maybe, if anything, a little worse. So this is probably my favorite image on this case, because if we look in this posterior left base, we have some abnormal density. Some of it's ground glass. You can see in the middle, it's ground glass. You can kind of see through it. You can see the airways and vessels, but then around the periphery, it's all consolidation. So you have central ground glass and an area of consolidation around it. And so we call this sign the reverse halo sign. opposite of the halo sign, where you have a central nodule or area of consolidation and ground glass around it, like you can see in angioinvasive aspergillus. This is the reverse halo sign, where you have central ground glass and consolidation around the periphery. And a lot of people call it the atoll sign because it can look kind of like a coral reef with the fluid in the, or the ocean in the middle and the coral around the outside. So the atoll sign, or the reverse halo sign. And it is a pattern you see in organizing pneumonia. It's actually how the process kind of clears. It clears centrally and spreads out. It was originally described as specific for organizing pneumonia, but they have described the reverse halo sign in other diseases, so it's not a pathognomonic. But most commonly, when you see the reverse halo sign, it will be organizing pneumonia, and you should think of that first. And organizing pneumonia is an abnormal host response to some type of lung injury. If we don't know the cause and it's COP, cryptogenic organizing pneumonia, if we know the cause, like let's say they had a bacterial pneumonia and then developed organizing pneumonia, then it's just OP, or organizing pneumonia. COP, cryptogenic organizing pneumonia, is an idiopathic interstitial pneumonia. If we know the cause and it's not idiopathic, but the process is the same. So what happens is you get an insult to the lung, and as part of the reparative process. So let's say it's a pneumonia, bacterial pneumonia, the infection is cleared, but your lung starts laying down granulation tissue in the alveoli, and to some extent plugs in the distal airways. And that's why it used to be called BOOP, or bronchiolitis obliterans organizing pneumonia. It can plug the distal airways. It tends not to cause air trapping or constrictive bronchiolitis. So BOOP is kind of now out of favor, and the term is just organizing pneumonia. But it is just granulation tissue as an abnormal host response. It responds well to steroids. It can relapse after steroid cessation, but then responds well to repeat challenges. Rarely it can progress to end-stage lung fibrosis, but that is uncommon. The cases I've seen it progress in tend to progress in a fibrotic NSIP kind of look, but usually it responds well to steroids. There are some other. So the reverse halo sign is not the most common sign we'll see in organizing pneumonia, but it probably is the most specific. Usually with organizing pneumonia, it can be hard to differentiate from bacterial pneumonia. You'll see consolidation along the axial interstitium, consolidation along the periphery of the lungs. But there are some other signs of organizing pneumonia that are uncommon in infections. And one of those is band-like consolidation. So you see how in this right lower lobe, we have a nice kind of straight linear band of consolidation. Unusual for infections to do that. And it's kind of like a variant of the reverse halo sign, is what's called the perilobular sign, or perilobular consolidation. So here you can see in this posterior left base, we have a nice secondary pulmonary lobule, looks pretty normal, but then everything around it is kind of trash. The lobule next to it is completely consolidated. So you've got a secondary pulmonary lobule and then all this perilobular consolidation around it. Again, and here's kind of more the same. Here's a secondary pulmonary lobule, and you see this perilobular consolidation. So the atoll reverse halo sign, perilobular consolidation, and band-like consolidation are all kind of manifestations of organizing pneumonia that are uncommon in bacterial infections. And here's the chest x-ray showing just kind of the extensive opacities. That was a movie of the same. So COP, cryptogenic organizing pneumonia, we don't know the cause. Almost anything can cause organizing pneumonia. It is common after infections. It's also one of the organizing pneumonia and NSIP are the two of the most common patterns of lung injury from drug toxicity. And you can also see a lot of organizing pneumonia in people with connective tissue diseases. All right, so we're getting closer to the end. This was somebody with Sjogren syndrome, which if you're familiar with idiopathic interstitial pneumonias, that should probably clue you in. So this is kind of a bizarre case. So we're coming down on the bases, and we do have abnormal ground glass. You can see there's all this ground glass density here. Here's probably some normal lung. A lot of abnormal ground glass kind of along the axial interstitium, or kind of peribronchovascular in distribution in areas. And in addition to the ground glass, we have these kind of funny looking cysts in the lung. So these are not honeycomb cysts. Let me come to the bottom one here. Well, this one actually touches the pleura, but a lot of these don't touch the pleura. You can see here it's separate from the pleura. So these are not true honeycomb cysts. They're not abutting the pleura and stacked up. Some of them are clearly off, separate from the pleura. And in addition to that, we have this kind of bizarre calcification. So here you can see some calcification kind of in the little sulcus there between the right lower lobe and the diaphragmatic crura, and several other areas of kind of this bizarre amorphous calcification. So we see a lot of calcium in the lung. We usually chalk it up to granulomatous disease, but granulomas don't do this. You can see it's kind of spread out along the mediastinal pleural surface. So this would not be your typical old histo or TB. And we have these funny cysts and the ground glass. And so what this is LIP, or lymphocytic interstitial pneumonia. You can see it with a lot of connective tissue diseases. For some reason, tends to be most common in Sjogren's syndrome. And what LIP is you get an abnormal polyclonal, so it's not a lymphoma like a Baltoma would be. You get an abnormal polyclonal proliferation of lymphocytes. So a lot of people with connective tissue diseases will get follicular bronchiolitis. So they'll have abnormal lymphocytes that kind of surround the distal airways. They can cause smudgy nodules, can cause some air trapping and some pneumatoceles. But if that abnormal proliferation of lymphocytes spreads out into the alveoli, then you get these more diffuse ground glass densities, and it becomes LIP, lymphocytic interstitial pneumonia, because now it's spread throughout the interstitium, not limited to the terminal airways. And we're recognizing more and more that LIP is frequently seen in, with the nodular type of pulmonary amyloid. And so these areas of bizarre calcification are actually pulmonary amyloid. So this is a patient with LIP and amyloid. There's just the coronals. So benign, diffuse infiltrate, predominantly lymphocytes and plasma cells. LIP is because of the lymphocytes, but it's not limited to the airways like follicular bronchiolitis is. Classically seen with Sjogren's syndrome, but you can see it in other connective tissue diseases. You can also see LIP in people with immunodeficiency syndromes. It's for some reason it tends to be common in pediatric AIDS patients, or multicentric Castleman's. You can see LIP. So the HRCT findings are ground glass densities, poorly defined centrolobular nodules, which is kind of the follicular bronchiolitis part. Peribronchovascular thickening, and then you get the lung cysts. Now, amyloid can cause cysts in and of themselves if you have that abnormal protein deposition. The amyloid in the airways, it's a check valve mechanism. So you create the little lung cyst, but also follicular bronchiolitis may, if you're occluding the terminal airways. LIP is tough. It can have a bunch of different looks. Here's some older imaging from the literature, which shows somebody with a different kind of look for LIP and multicentric Castleman's disease. And here you can see just a lot of perilymphatic thickening, kind of irregular, smudgy, and nodular in areas. Here's a different patient. This was somebody with AIDS, and this was biopsied and was LIP. And you can see a lot of ground glass densities and centrolobular nodules. So probably a lot of follicular bronchiolitis in addition to the LIP. Here's one case that looks more like the case we had or that I showed earlier. And this was somebody actually with Sjogren's syndrome. So these cysts, these larger cysts, and probably there's some bizarre calcification in here that they didn't describe in the article, and it's not windowed and leveled appropriately, but this is probably somebody with Sjogren's and both LIP and amyloidosis, and it has kind of a similar look to the earlier case. And then sometimes it can look like pulmonary edema or lymphangitic carcinomatosis, where you see kind of conspicuous septal thickening. And this was another case of multicentric Castleman's. And so to finish up, the last of the rare idiopathic interstitial pneumonias is what's called ppfe. So it can be an idiopathic interstitial pneumonia. It gives you upper lobe predominant pleuroparenchymal fibrosis. There's a lot of elastin in that fibrosis. So if you do biopsy it, you want to do an elastin stain to prove it. There's no good therapy for it. So it doesn't change management to biopsy it. So we don't biopsy it very often if we suspect it. But if you do biopsy it, you want to get the elastin stains to prove that it's fibroelastosis. Very rare idiopathically. You do see the same process in people who've had lung transplants. So the most common type of allograft rejection in lung transplants patients is bronchiolitis obliterans. So bronchiolitis obliterans syndrome or constrictive bronchiolitis is what causes most long-term lung transplants to fail at 5 to 10 years. That's the obstructive form of CLAD, or chronic lung allograft dysfunction. The restrictive form of CLAD, chronic lung allograft dysfunction, or what chronic rejection looks like, is ppfe. So in a minority of patients who've had a lung transplant, they'll get this kind of dense upper lobe pleuroparenchymal fibroelastosis, and it can cause their lung transplants to fail. But you'll see on CT, you'll see dense subpleural consolidation, traction bronchiectasis, architectural distortion, and upper lobe volume loss. And here's just an example from the literature, because we don't have a lot of path-proven cases because we tend not to biopsy it much. But this is what it looks like in the literature. So you get a lot of pleural thickening and then nodular kind of apical scarring. Sometimes it can be hard to differentiate just from old granulomatous disease. If you CAT scan a lot of people, they'll have apical kind of pleuroparenchymal scarring. But if it's ppfe, it tends to occur in a little bit younger population and is progressive. So if you have imaging going back 5 years, it should change, whereas the kind of typical apical scarring tends not to progress. And so the median age is around 57 years. They can get pneumothorax and recurrent infections, progressive disease in 60% of patients, and then 40% of those die. And so that is it on the idiopathic interstitial pneumonias. I can check the chat, or if anybody wants to ask questions.
Well, that's a really fantastic lecture. Thank you so much, Dr. Watts. Yeah, I think that's one of the strengths of these lectures, especially to bring in some of the pathology and the clinical perspective in it. Just really makes it a very strong lecture. One area, I'm going to wait for some questions to come in as well. But one thing that I think that we see a good bit now, and kind of the COVID getting into some of the post-COVID era, is that patients with a history of severe COVID pneumonia are developing some of these interstitial lung abnormalities. Is that something that you see frequently when you're reading these chest CTs?
Yeah, we see a lot of post-COVID. The good news is that most of it kind of, it's a kind of a post-COVID organizing pneumonia. You'll get these curvilinear bands that will kind of arcading at the periphery of the lung. Most of that goes away. In a small percentage, it will progress to fibrosis. So if they actually had severe COVID, got ARDS, were intubated, then they frequently will have like post-ARDS fibrosis, which can be severe. A lot of times it gets better though, but the people who are not hospitalized or not intubated, not in the ICU with COVID infections, didn't have true ARDS, they are getting some post-COVID fibrosis in a small percentage, and I forget the numbers, but it's like 5 to 10% at 1 year of follow-up will still have some abnormalities, which the fibrosis that we see is going to be kind of some areas of traction bronchiectasis and architectural distortion. You don't see the like UIP pattern in post-COVID fibrosis. you'll just see they'll have like the bad disease. A lot of it'll clear. The subpleural lines, the kind of curvilinear banding and arcades will clear. The part of it that's actually organizing pneumonia will go away, but some of it can persist as fibrosis, and we'll see that. And they can also get a constrictive bronchiolitis, so they can get a small airways disease that's actual scar that doesn't go away. So I'll do, like, my protocol at the VA is for the post-COVID follow-ups. We don't do them prone because it's not usually limited to the posterior bases, but I will do supine, inspiration, and expiration to make sure that we're not missing some constrictive bronchiolitis in addition to kind of the traction bronchiectasis that we can see.
Excellent. Well, we do have a question here. Can the UIP pattern also be described as a crazy paving pattern?
Well, no. So a UIP pattern would be the overall disease pattern. So it has to have the distribution, it has to have honeycombing and reticulation. Crazy paving is where you see intra and interlobular septal thickening with ground glass superimposed. So there could be areas of reticulation that kind of look ground glassy that would look like a crazy paving pattern. So you could like take small areas and say, yeah, that's probably a crazy paving. You could call that a crazy paving pattern, but the overall appearance would not be the same. So if the overall appearance you saw mostly just crazy paving, you would think about other diseases, the classic one being pulmonary alveolar proteinosis, but and you can see it in pulmonary edema and some other things. So yeah, if you did see an area of crazy paving, it would have to kind of be small and limited to the area of reticulation, or you should probably think about some other disease process.
All right, excellent. So I believe that we've answered the questions that are in the Q&A. I'll ask one more question to close since we're coming up at time. So what is important for radiologists to report in these studies of concern for interstitial pneumonias from the clinicians who are ordering these studies?
So I think using the ATS or Fleischner terminology is important, because if you report, say, this may be UIP, that's not all that helpful, because they don't know if it may be enough that they don't need to biopsy it, or should they biopsy it. So if the pulmonologists know kind of the workup with the terminology of the ATS, so they know if it's typical UIP or probable UIP, they can do their serologies, they'll check an exposure history. If all that's negative, they have a diagnosis, IPF. If it's indeterminate for UIP, there's a possibility it's HP. They'll do other things, and if they still can't come up with an answer, they will go to biopsy. And we still biopsy people. I mean, every week we have a couple of people we biopsy at ILD conference. But the decision, especially if you don't have like a multidisciplinary conference, if you have just like a community pulmonologist reading the report, I think the most important thing would be to use the terminology correctly. So probable UIP or typical UIP, as opposed to maybe UIP or favoring UIP, which people kind of do sometimes. So yeah, the pulmonologists, at least the ones I'm familiar with, are very aware of the workup using the ATS terminology. So that terminology, I think, is probably the most important thing to include in your report.
Excellent. All right. Well, we do have one more question in the chat if we have time for it, and this is just asking when you decide to do a supine versus a prone scan for the IP workup.
Sure, and that's a good question. The guidelines, the ATS guidelines say you can do, and what a lot of places do is they'll do a full volumetric supine inspiratory scan, and then they'll do limited cuts and expiration and limited prone cuts, and you can do that with the gap. So you can do that at the 1 millimeter thickness at a 10 millimeter or 1 centimeter gap. At UAB and at the VA, we do almost all of them just prone. We do them prone, volumetric inspiration and expiration, because the dose is pretty low with the newer scanners. And we've had issues trying to figure out like when to, it's hard to leave it up to the technologist to decide if there's enough dependent density that they should get prone imaging. And it's not really, it'd be hard for workflow to ask the radiologist for every scan, do we need to get some additional prone imaging? So we do it all prone in both inspiration and expiration, but that's not the most common practice. The most common practice, and what the ATS guidelines say, is you could do supine, full inspiration, and then if there's any question of dependent density, you do the limited imaging and prone. So I would recommend either doing them prone, inspiration, and expiration like we do, or just always getting some limited prone imaging after you do your full volume supine inspiratory scan.
Excellent. Well, I think that brings us to time. Excellent lecture, excellent discussion. Thank you so much, Dr. Watts. Thank you for this great opportunity to highlight this work, or to highlight this topic. And if there are any additional questions, we will hopefully be able to get to them on email or Twitter. And thank you for thank you for this opportunity today, Dr. Watts.
Great. Thank you, George.